You're listening to a podcast of the World Stroke Academy, the educational platform of the World Stroke Organization. Future Stroke Leaders is an initiative of the WSO to develop the technical and research skills of the next generation of stroke professionals. The World Stroke Academy welcomed the contribution of the Future Stroke Leaders members by inviting them to cover specific stroke-related topics in our Pearls Podcast initiative.
Hello everyone, welcome to the World Stroke Academy Pearls Podcast series. I am Dr. Matías Alet, a stroke neurologist from Buenos Aires, Argentina, and a proud member of the Future Stroke Leaders program of the World Stroke Organization. Before we begin, I would like to express my gratitude to Dr. Nishant Mishra, Assistant Professor of Neurology and Stroke Neurologist at Yale University School of Medicine, who leads a large post-stroke epilepsy research consortium called International Post-Stroke Epilepsy Research Consortium, IPSRC, who kindly agreed to supervise me with this podcast. Today, we will give an update about the diagnosis and treatment of post-stroke epilepsy. We must remember that 1 in 4 adults will develop a stroke during their lifetime, with significant consequences. Among these are acute symptomatic seizures and post-stroke epilepsy. A stroke represents, by far, the most common cause of epilepsy in older adults. First, let's introduce a real case of a patient I am following at my office. You may have encountered a similar case at some point. This patient is a 65-year-old man who had a stroke in the territory of the left middle cerebral artery and received acute reperfusion with thrombolysis and mechanical thrombectomy. In the CT scan made 24 hours after treatment, there was evidence of a stroke in the frontal and temporal lobe without hemorrhagic transformation. The patient was discharged with an AIH score of 10 points and started rehabilitation. 2 months later, while he was having breakfast, he had a sudden tonic posture of his right arm, followed by a loss of consciousness and a tonic-clonic seizure that lasted 5 minutes. He was taken to the emergency room, where metabolic or infectious alterations were ruled out, and a CT scan showed no changes compared to the discharge image. It was interpreted like post-stroke epilepsy, and treated with anti-seizure medication was initiated. Since then, there have been no recurrent seizures. So let's start by exploring the definitions and epidemiological aspects. What are the current trends we are seeing in terms of post-stroke epilepsy? First, we will give important definitions. Early seizures refer to stroke-related acute symptomatic seizures that occur within 7 days of a stroke. In contrast, unprovoked seizures that occur later than 7 days after a stroke are called late seizure or post-stroke epilepsy. Accurate classification is really necessary, as this carries different implications for treatment and prognosis. The ELAE states that epilepsy exists in a person who has had 1 unprovoked seizure and has a probability for the recurrence of further seizures of at least 60% over the next 10 years. Accordingly, post-stroke epilepsy can be diagnosed after a single unprovoked late seizure, those that occur after 7 days of the stroke. Early seizures, those that occur within the 7 days of a stroke, arise from transient change in neuronal excitability due to acute biochemical dysfunction and excitatory neurotransmitter release following the acute ischemic brain injury. The late seizures are the results of the brain acquiring a predisposition for the generation of unprovoked seizures through epileptogenic pathways. The acute symptomatic seizures occurs at least 3 to 6% of patients with a stroke. The risk is greater in hemorrhagic compared to ischemic stroke. a lower ICH or subarachnoid hemorrhage, and ischemic stroke with hemorrhagic transformation provide a greater risk, and the majority occur within the first 24 hours after stroke. Post-stroke epilepsy varies between 2 to 15%. The risk is generally higher after an hemorrhagic stroke. So, moving on to our next segment, let's talk about the risk factors that are associated with post-stroke epilepsy. What are some of the key factors that increase the probability of post-stroke epilepsy? The patients with hemorrhagic stroke, the hemorrhagic transformation in case of ischemic stroke, the cortical stroke location, the clinical stroke severity, and the lesion size, and the younger age are at the greater risk of post-stroke epilepsy. Also, a previous acute symptomatic seizure, the cortical stroke location, uh, are greater factors, risk factors for this probability. A very interesting point of discussion is the association between acute stroke therapies and seizures. There has been uncertainty about the effects of acute stroke reperfusion therapies on the post-stroke seizure risk. Some studies have suggested that thrombolysis and endovascular thrombectomy increase the risk. Other studies, however, did not find such association. The treatment selection bias might confound comparisons between these groups of reperfusion therapy and those without reperfusion therapy. But a recent study found that the reperfusion therapies were not associated with an increased risk either of acute symptomatic seizures or post-stroke epilepsy. Now let's discuss prediction scores. Can we predict post-stroke epilepsy? Information about risk factors is available in clinical practice and can be used to predict a patient risk for developing post-stroke epilepsy. The SELECT score uses 5 of risk factors as predictors: the severity of a stroke, large artery etiology, early seizures, cortical involvement, and the territory of the middle cerebral artery involvement. There's other score, the CAPE score, that has been developed to predict the risk of seizure after ICH. It uses cortical location, younger age, the hematoma volume, and acute symptomatic seizures. But we should highlight that both scores were based in a relatively small cohort of patients and actually have a poor validation. Moving to our next question that is fundamental. How should we diagnose post-stroke epilepsy? Mainly the diagnosis is based on the definitions. We use the 7-day cutoff as a rule, and this will probably allow seizures to be attributed correctly as either acute symptomatic seizures or epilepsy in most cases. However, the clinical situation might sometimes be more complex, so it could be a little more difficult to distinguish between these two etiologies. If it is in doubt whether a seizure is truly unprovoked, the diagnosis of epilepsy should not be made. And obviously, a post-stroke seizure might not necessarily be stroke-related. So we need a clinical correlation between the semiological feature of the seizure and the location of the stroke lesion. The main role of the EEG is to detect subclinical, exclusively electroencephalographic seizure activity. Most seizures in critically ill patients that are recorded are in the continuous EEG, but they do not have any detectable clinical signs at the bedside, and they would be myths. So, continuous EEG is a tool that should be performed in all critically ill acute stroke patients who show persistent impairment of consciousness or sudden changes in mental status. but the role of the EEG for predicting post-stroke epilepsy, whether alone or in combination with other tools, needs further investigation. In the next segment, we will explore the treatment considerations for post-stroke epilepsy. What are the current treatment options that we have available, and how do they vary based on the established diagnosis? Regarding stroke-related acute symptomatic seizures, anti-seizure medication directly after stroke for primary prophylaxis is unjustified due to the relatively low incidence of acute symptomatic seizures. Even in some high-risk scenarios, the risk is only 30-35%, so the primary prophylaxis is not recommended. After a first stroke-related acute symptomatic seizure, another seizure can occur, and it happens only 10-20% of the patients. On this relatively low risk, there's a consideration for temporary acute symptomatic treatment to prevent a second seizure, but it's not really recommended by guidelines. But nevertheless, in clinical practice, the patients are often started with an anti-seizure medication with the aim of preventing a new seizure and to avoid a clinical worsening in this scenario. This is a pragmatic approach, but it's not evidence-based. The importance here is that there is no evidence that a long-term treatment will reduce the risk of develop epilepsy. So, if treatment was chosen and was started, these anti-seizure medications should be withdrawn after the acute stroke phase, ideally before the patient is discharged. Regarding treatment with anti-seizure medication in post-stroke epilepsy, in this scenario, the treatment is advised. After a first unprovoked seizure, the patient should be informed that there is a risk of recurrence and we should offer them treatment. The importance in this scenario is to start slow and to aim slow and obviously try a monotherapy in post-stroke epilepsy. We must consider that these patients with stroke are a special population. They have altered pharmacokinetics with age. They are taking multiple medications. So, if we take into consideration, for example, drug interactions, some medications as carbamazepine, phenytoin, or phenobarbital are the less ideal treatment in these patients. If we should take in consideration, for example, which are the more favorable treatments, for example, levetiracetam, lamotrigine, or gabapentin could be good options. Let's talk about outcomes. So, what are the primary outcomes that healthcare providers and researchers are focused when managing post-stroke epilepsy? So, we should remind a few tips. Overall, the seizure freedom rate might be similar to the general epilepsy population, that's around two-thirds. The anti-seizure medication withdrawal should be approached with caution in this population, and any decision will be need to be individualized for each patient. A drug-resistant epilepsy is rare, but could be presented in patients, for example, after an hemorrhagic stroke or with high stroke severity. The neurological function and outcome of neurorehabilitation in post-stroke epilepsy patients is largely determined by the stroke severity, and the evidence regarding quality of life in this population is scarce, but the seizure frequency, depression, and functional impairment were identified as independent predictors of poor quality of life. So, I would like to remind you that Dr. Mishra is leading a large international effort called IPSARC, and it brings together stroke and epilepsy scientists worldwide and promotes science to prevent post-stroke epilepsy. That's very important because it will reduce the risk of patients being on anti-seizure medications for the rest of their life, improving their quality of life. As we wrap up today, in this episode, here are some final thoughts and key takeaways I would like to leave to our listeners. First, the understanding of post stroke epilepsy has improved, but several issues still require further investigation. Research is needed to better characterize the mechanisms of epileptogenesis after stroke and to identify biomarkers for epilepsy development. Second, stroke-related acute symptomatic seizure and post-stroke epilepsy differ in their pathophysiology and time of presentation, and an accurate classification is necessary as this carries different implications for treatment and prognosis. Third, the diagnosis is mainly based on clinical definitions using the 7-day cutoff as a rule. The main role of the EEG is to detect subclinical seizure activity. Some neuroimaging, advanced neuroimaging, should be performed only in doubt. And last, the primary prophylaxis with anti-seizure medication after stroke for acute symptomatic seizures is not recommended. And in post-stroke epilepsy, an individualized treatment decision is crucial, and we have to consider factors like age, comorbidities, and potential cognitive side effects of our choice of anti-seizure medications. If you want to read more about this topic, you can review the resources provided. And it's been a pleasure participating in this podcast series. I want to express again my gratitude to Dr. Nishan Mishra for his collaboration as a mentor for this podcast and to the World Stroke Organization and the World Stroke Academy for the opportunity. I am Dr. Matías Alet from Buenos Aires, Argentina. Thank you very much for listening.
Thank you for listening to this podcast. You can find additional stroke education material and resources in our World Stroke Academy website and social media channels.